Everybody,
Hello.
I see you turning on your videos. Thank you very much. I appreciate that a lot. I'm going to, well, maybe it's, and I'll start in 1 minute because we do have a lot to get through. I'm going to record it. I haven't recorded our previous stuff because, you didn't really need to, but I'm going to record the lecture and post it. So just, if I start and forget to do that, because if I start talking to you about something, would you remind me? I want to record it. So I'm, oh, apparently it's recording the whole thing. Oh, darn. Okay. I guess we're recorded. I'll try to cut off the first part because that's a lot of stuff we don't need. Anyway. Okay, so I'm going to go ahead and share my screen, and we are recording, and yep, we're good. Let's see, share screen. It's our slides, and they are posted there for you. I'll always follow the same pattern. I'll post the slides. We'll have a live lecture like today, or a recorded lecture, and you can go along with the slides. As you know, you can make notes and stuff, whatever works for you. Okay, so this is an overview of the course, and we've already done that. We went through the syllabus, et cetera, et cetera. So now the slides really have to do with the 9 impairments of swallowing. And they could be classified differently, but the ones I've called impairments, there are 9 of them. So why are we focusing on impairments right away? As I already said, because I want to form them. This will be the basis for a focus on treatment and management. It starts with what is the impairment, and then every time you identify an impairment, there will be a choice of rehabilitative treatments, meaning treatments that are actually intended to improve the swallow, and there will be a choice of compensatory, you could call them treatments. Sometimes they're compensatory management strategies, might be a better term. For example, if you find a patient who does aspirate certain things and they cannot independently follow any precautions or do anything that you ask them to, one choice would be simply to change their diet and the nature of the liquids they're drinking so that they will be safe. That's not really a treatment, but it certainly is a management strategy. And so either treatments or management strategies that are compensatory. You can change the diet. You can also change the way they're swallowing. For example, you might ask some patients to swallow twice, every dose to swallow twice in order to clear the throat of the residue that's left behind. And some patients you can teach to do that independently. So you do have therapy sessions in which you're teaching them to do it and giving reinforcement just as you would in the kinds of therapy you're experienced with. That's a treatment then in that case. But it's a treatment with teaching of a compensatory strategy. Okay, so
Professor?
Anyway, it all starts with the impairments. That's my point with this slide. Yes?
By diet, are we talking about like the textures, like things that are thin or thick, or the viscosity of liquids and that stuff?
All that stuff, yes, by the nature of the diet, yeah. We'll have one whole lecture on that. So you'll know the choices. So, at this point, it's, as I said, this lecture will be introductory, but I don't expect you to have a full or complete understanding. We'll flesh that all out through the course. Okay, all of our 9 impairments fall into one of 3 categories, and each category corresponds to one of the main 3 phases of deglutition. So there are impairments of the oral phase, impairments of the pharyngeal phase, and impairments of the esophageal phase. The esophagus can have some dysfunction. For example, it can have blockages or motility problems. It can have reflux where everything's swallowed fine until it gets down to the esophagus and then it comes back up again. That whole esophageal area is in somebody else's professional domain, not ours. And that is the professional domain of a physician called a gastroenterologist. They deal with the entire digestive tract, start to finish. But mostly they leave the oral and the pharyngeal phase to the SLP. So we fully evaluate far more fully than any other discipline. We fully evaluate the oral and pharyngeal phases of the swallow, and we can identify when impairments fall into one of those. For impairments of the esophageal phase, we need to be able to screen them. We need to be able to identify there's something going on with the esophagus, probably, but not to diagnose it. And then once we identify that there's something going on with the esophagus, probably, we refer that individual to a gastroenterologist. So we certainly need to be able to screen it, but not to diagnose it. So you'll notice that as we go through impairments of the esophageal phase, we're not going to go in so much detail. Oral and pharyngeal phase, more detail, far more detail. Okay, impairments of the oral phase amount to these. You can have impaired ingestion of the material into the mouth. Simply, how do you get it into the mouth? Partially, that's within the scope of the occupational therapist, who's called an OTR for registered occupational therapist. That part they're involved in is how do you get it basically from the plate, in a simplified term, how do you get it from the plate to the mouth? It's the use of the hand and the use of the utensils. We don't get much into that, but you do have to observe it. You have to know, can your patient get material to the mouth or not, at least to that level. We're not going to design a treatment plan for it, but we do start with that. You know, can they even put a cup to their lips? If they can't, obviously we're going to have to write swallowing precautions differently. So it starts with there, but we don't get into a lot of detail. Certainly we do assess by observing how the patient ingests the material. How do they actually, not how do they get it to their mouth, but how do they get it in? Can they, for example, purse their lips around a cup or around a straw? We observe that. Can they remove the material from a spoon? Do they have enough pressure of the upper lip and the tongue to remove materials from the spoon? So we look at how do they get it into their mouth? Not so much how do they get it to their mouth, but certainly how do they get it into their mouth? Then we start looking at oral preparation. And oral preparation problems, impairments of oral preparation, can fall into different subcategories. One is a delayed initiation of oral preparation. You'll see that often in patients where you put some pudding into their mouth, and it's in their mouth, it's on their tongue. They're not doing anything. That's delayed initiation of oral preparation. And so that's one thing. And of course, we'll go into a lot more detail on that. Another is disorganized oral preparation. And that would include, for example, start and stop. They start oral preparing and then they stop, and then you remind them to keep going. Or they lose material. They can lose material beneath the tongue. They should keep it all in a nice little packet called a bolus at all times while they're preparing it, but they can lose it. They can lose it into the buccal cavities. They can lose it down into the throat too. So that disorganized oral preparation. And a third subcategory of impaired oral preparation is disorganized oral preparation, including problems of timing, as well as loss of material into all of those areas. So,
Dr. Kitzelman?
Yes.
Question. Regarding MBS-IMP,
Yes.
the disorganized swallowing, when they classify it in that way, you know how in MBS-IMP they say has to be 3 or more movements back and forth. Would that fall under 2 or 3?
I think it's actually what the same. Yeah. As I look at my slides, I sort of could take out the second one because it doesn't really say anything different from the third one. The third one says disorganized oral preparation, including timing problems as well as loss. So I think my slide is a little bit redundant in that regard. So I'd say 3.
Okay, so disorganized does refer to that type of movement, though, that correlates with the MBS-IMP, the 3 movement thing component.
Yep.
Perfect. Thank you.
Okay, and then there's the third one. The third main thing would be impaired oral transfer, and that includes delays in it. That, for example, the person has prepared the bolus and they're containing it, but they don't push it back in a timely way. It could also include incomplete oral transfer, where they do push it back, but not all of it. Generally speaking, when you push it back into the throat, when you push a bolus back into the throat, it should all be out of the mouth. So a lot of times it's not, usually because the tongue is too weak to create the amount of pressure needed to push it fully back. And the final one can be disorganized oral transfer function. And this mainly is where they're trying to transfer it, but they're not initiating an oral transfer effectively. And what is happening instead is a bit of the material is being lost. I'm using that word very purposefully, lost, not transferred, but lost into the pharynx, which can become problematic because once it's lost into the pharynx before they're really ready, they have a very good chance of aspirating the material or choking on it. So the three impairments of the oral phase are impaired ingestion of material into the mouth, impaired oral preparation, and impaired oral transfer. And we have some subcategories and further description. Most of the language used here is what I would just call everyday observational language. In other words, we don't exactly have professional terminologies here in this part. When we get to the pharyngeal phase, there will be a lot of terms and descriptive labels which are highly agreed upon among SLPs and tend to we use those things in the same way. Not so much here. This is just like everyday language, and we're describing things as best we can see them. If you're doing an MBS, you can see them very well. If you're doing a bedside swallowing eval, not so much. I mean, something like premature oral loss, you can't really see it clinically. You can see some clues that it might be happening, but you can see it very clearly if you're doing a modified barium swallow. Okay, now, impairments of the pharyngeal phase. Here's where we get into terminologies that are used pretty much of the same way among different SLPs. The first is a delayed or absent pharyngeal swallow response. And notice I'm numbering them. So I've had 1, 2, 3, now I have 4, 5, 6, 7, 8, and then we'll get to 9. Delayed or absent pharyngeal swallow response. The pharyngeal swallow response is the whole series of things that occur in the throat. And basically it amounts to pushing the material in the throat from top to bottom, pushing it like you push toothpaste out of a tube, the muscles push, while keeping the airway closed. And it's got to be in kind of a certain sequence. So it actually starts at the top when we look at number 5. The first thing, or the topmost thing that could occur, is the material's been pushed partially back into the throat and it's starting to be compressed downward, but the velopharynx hasn't closed. And so with that compression, it's going to drive some of the material up into the nasal cavity, and there's going to be what's called nasal reflux. So let me return to my point. I'm just trying to say there's this whole series of things that got to occur in a certain kind of sequence. That is referred to as the pharyngeal swallow response, that sequence of activities that occur in the pharynx. It used to be called the pharyngeal swallow reflex, but I think it was Jerry Logeman, who was the writer of the first text, and I couldn't think of her name, even though she started the field. Jerry Logeman started telling us that, the pharyngeal swallow response is too complex to be called a reflex. When you tap the patellar muscle and the leg kicks out, that's a reflex. But the pharyngeal swallow response has so many things occurring in it that it's a little more complex than a reflex. So she started referring to it as a pharyngeal swallow response. So it's a series of relatively invariable activities that occur for the purpose of swallowing in the pharynx. Okay, it can be completely absent. In other words, you don't have one, which is obviously you're not going to be able to eat. You can swallow. I've seen people who had a stroke in a certain part of the brainstem that takes out their pharyngeal swallow response. And they say they can swallow because they're doing the oral part of it, which is conscious. They're pushing it back and it isn't in the mouth any longer, but it hasn't gone into the esophagus. It's gone into some of the little crevices in the pharynx and just sitting there, or if they swallow more, goes into the airway, but they're not having a pharyngeal swallow response. So that can occur, and we'll talk about the neurology of that in 2 weeks. Actually, next week, I think. And then you can have a pharyngeal swallow response, but it's delayed. And that's very common in neurological injury or disease, is that it's delayed. And what happens is the person transfers it back. The oral transfer can be effective. It's not in the mouth, and it's sitting down in the pharynx someplace. You can accommodate about a teaspoon in some crevices and nooks and crannies that are in the pharynx. But if you take a sip of more than a teaspoon or a dose of more than a teaspoon, it's got to go somewhere. And that somewhere will be the airway. They will aspirate it. So that's a very important impairment, delayed or absent pharyngeal swallow response. The next thing that can occur is there's impaired velopharyngeal closure. The material gets there, the velopharynx isn't closed tightly enough, and some of it goes up. If you've gotten into your MBS-IMP, you've already rated that. Okay. The next thing that can occur is impaired pharyngeal motility. That motility is created by the tongue and the pharyngeal constrictors, and they constrict in a certain sequence from top to bottom to push it down. Has nothing to do with gravity. You can swallow while standing on your head because your muscles are pushing it, just like the tube of the toothpaste. And it can be, impaired pharyngeal motility can be asymmetrical or symmetrical. You can have a weakness on both sides of the throat, or you can have a weakness on one side of the throat, in which case what you're going to see is you're going to see residue, which we call stasis, S-T-A-S-I-S. I spell it some other place, but we have stasis. After the pharyngeal swallow is all done, there's still stuff, stasis, either on one side, which would be asymmetrical pharyngeal dysmotility, or it's on both sides, which would be symmetrical pharyngeal dysmotility. So the evidence is the stasis. There's the word. I forgot I had it there. And it can be found after the pharyngeal swallow in the valleculae, epiglottic valleculae, or in the piriform sinuses, or it could just be coating the pharyngeal walls and the posterior third of the tongue, which are all part of the pharynx. We're going to go into the anatomy of the swallow, so we'll get into this. I know you kind of know it, and maybe you know it very well from your anatomy and physiology class, but just in case that's not crystal clear at this moment, it will be next week. The other thing that could occur is impaired laryngeal closure. Your pharynx can be pushing things down just fine, but the larynx needs to be closed, and it needs to be closed tightly, because with all that pressure being generated to drive the bolus downward, if the larynx isn't closed tightly, it will go into the larynx. And then depending how much, it can get down into the trachea and down into the lungs, and they can get sick from that. So impaired laryngeal closure. And then the final thing that can occur is cricopharyngeal dysfunction. The cricopharynx is the valve, the sphincter, I'm going to use the word sphincter, at the base of the pharynx. And normally, as you're just sitting there, all of you right now, unless you swallow something, including saliva, that valve is closed. And there's another valve at the base of the esophagus that's also closed. You got two valves, one at the top, the upper esophageal sphincter, one at the bottom, the lower esophageal sphincter. And as you sit there in a relaxed state, the valves are closed. When you swallow, they open up. The top one first, the bottom one next, when the time comes. And it allows the passage of the bolus from the pharynx into the esophagus. So that can go wrong, and that would be called cricopharyngeal dysfunction, and that's 8. Now, I just want to point out one thing. I've got them listed like it's a sequence of things that goes 1, and then 2 happens, and then 3 happens, and then 4 happens. There's a considerable overlap. So it's not quite as linear and sequential as indicated, but it is somewhat. You have velopharyngeal closure occurring before you have an opening of the upper esophageal sphincter. Does that make sense? So it's somewhat sequential, but also overlappingly sequential. Okay, let me go to the next one. Oop, not that far. And then we get to esophageal impairment number 9. That's the last one. And here I mention again, which I said earlier, diagnosing and treating esophageal impairment is in the scope of practice of the GI doc. But we do screen for it, and you can screen for it with modified barium swallow definitively, and with fees definitively. In other words, you can identify that there is a problem. You just don't know exactly what problem, because the esophagus can have more than one type of problem. And so we screen for it, and then we refer on to a GI doctor. Okay. Okay, now here's a point that's quite important. And even experienced SLPs I've seen many times miss this point. Swallowing impairments are treated only if the impairment is handicapping, meaning it's bad enough to make a difference. So you can have a little bit of pharyngeal dysmotility where you do have residue after the swallow, but it never causes a problem. They don't aspirate it, they don't choke on it, they don't complain about it, they don't modify their diet because of it. The patient has the impairment, but in the example I just gave, it's not handicapping. We would not treat that. We wouldn't change their diet. We wouldn't have them double swallow. We wouldn't do therapy. We wouldn't do anything, because it's a non-handicapping problem. Does that make sense so far? Yeah, and so we're going to focus always on handicapping problems. And here are the features that make any one impairment handicapping. One is the patient chokes more frequently or more severely than is typical. We all choke, but what's the absolute cutoff? I don't know. But if somebody had the Heimlich maneuver 3 times, I would say that's a significant choking. I've choked, you've choked. I've never had the Heimlich maneuver. Has anyone ever had the Heimlich maneuver in this class? Yeah, so that objective fact would be enough that I would say that's the impairment that causes that choking that we would identify on a modified barium swallow or a fees. That impairment is handicapping, because you shouldn't be choking and getting a Heimlich maneuver. Maybe once, I don't know, but not many times. Okay, the other thing that could make an impairment handicapping, and this is quite subjective, but it is that the symptoms the patient finds are unpleasant enough to interfere with daily living. Maybe they're coughing, and it's so they're coughing during their meals. And let's say that the patient is not aspirating. In other words, we've seen an impairment on the modified. We see that it's causing coughing, and then we see that the patient says they never eat with anybody else because they find that the coughing is embarrassing or disruptive. That has interfered with daily living. And you'll find other patients who maybe cough the same amount, let's say 2 times a meal, but they live their life completely normally. They haven't been sick, they haven't gotten aspiration pneumonia, they haven't had the Heimlich maneuver. They go out to eat with anybody and they say, oh, I don't care, cough a couple times a meal. See, so it's the interfering with daily living that is the key to that. And how do you find that out? By talking to them and asking them. So if you tell such a patient who has this potential issue, the way I would deal with that is I'd change you to a pureed diet. Would you like to do that? That's a mushy diet, Would you like to change to a mushy diet, or would you like to cough 2 times a meal? Some people will say, well, I'll take the pureed diet. And a lot of other people will say, I'll cough 2 times a meal. In other words, they don't want the treatment. Okay. Aspiration can be handicapping, and very often is. Aspiration means getting food or liquid into the trachea and down below. And eventually, if it goes into the trachea and you don't cough it out, it's going to run down to the lungs. And if you do it, and if you aspirate enough, it's going to be make you sick. You're going to get aspiration pneumonia and potentially die. Many people with strokes have died from aspiration pneumonia. and other neurologic disease too. In fact, you know about ALS. You guys know about amyotrophic lateral sclerosis. Yeah, almost every person with ALS dies of aspiration pneumonia. That would be the main cause of death in somebody who has ALS, aspiration pneumonia. So clearly you can aspirate too much and often do. But on the other hand, sometimes the treatment for the aspiration is worse than the aspiration itself, as in a person who has never gotten sick. Maybe they have been aspirating chronically, but they've never gotten sick. It's never caused them to alter their daily living, et cetera, et cetera. You talk to the doctor and they say, I think they can, aspirate 2% of 1 out of 10 of their liquid swallows. They have very healthy lungs. We all do aspirate, by the way. We all aspirate at night, saliva, because your consciousness level is sufficiently low that all the swallowing protection is not there. And so you do aspirate saliva at night, and we're all here. So you can tolerate a certain amount. How much is a discussion between you and the physician about the cost benefit. So I would say aspiration is handicapping. And then I worded it this way because I think it works pretty well, especially if the degree is medically unacceptable. In other words, it's not always medically unacceptable. Sometimes the treatment and management is worse than the disease. And so that's a case where you might say, in this case, aspiration is not handicapping. We've never gotten sick from it. Physician is okay with it. We're just going to tolerate it. And then the last one is the inability to ingest enough to maintain healthy hydration or nutrition when that disability is due to dysphagia, when that inability is due to dysphagia. In other words, sometimes, for example, you could be anorexic and not be ingesting enough to maintain weight, but it's not due to dysphagia, it's due to something else. And so we're not going to manage that in any way. It's a different kind of problem. So if it's due to dysphagia, we would manage it. And it's very common actually in people who, for example, have Alzheimer's disease that's quite advanced. They sort of lose control of their oral, and they tend to let stuff sit in their mouth. And because of that whole process, they don't take enough in. And so we would change their diet generally, or do 6 smaller meals a day instead of 3. I mean, there are a number of things we could do, but that's handicapping. So I've listed 4 features of that make an impairment handicapping. And there might be more, but I think that's 99% of features that can make an impairment handicapping, and that we would therefore treat or manage in some way. You okay? Okay. Now let's deal with aspiration and penetration. Aspiration is taking material into the airway, and here's the key part, to the level of the trachea. You can also take material into the airway, but only to the level of the larynx. In other words, it doesn't get below the vocal folds. Okay, and so we'll see material go into the airway a lot. If it only goes down to the vocal folds, we'll refer to it as penetration. If it goes further, it's aspiration. And actually, just so you know, the term we're talking about as SLPs dealing with swallowing issues is known as prandial aspiration. What other kinds of aspiration into the airway are there? If a person is unconscious and vomits, they're going to aspirate their vomitus. In other words, it's going to come up and they're not controlling anything, they're not protecting their airway, and they'll take a breath and inhale vomitus, which is very bad for the lungs. They'll generally get very sick real quick. But that's not prandial aspiration. Prandial aspiration is aspirating when you're eating or swallowing. Aspiration of vomitus is not. Another example of where there can be aspiration is where there is A tube feeding, there's a tube that goes through the nose, the pharynx, down through the esophagus and into the stomach, and the patient gets fed with that. They've got a tube going through the UES and the LES, upper esophageal sphincter and lower esophageal sphincter, and that tends to cause reflux of gastric contents just from the pressure of the abdomen, like pushing, and the two valves are compromised and material will go up. And once it goes up, the whole swallowing, if that's not swallowing, that's getting material into the pharynx in a very atypical way, and they will generally aspirate it. They will just take a breath and what's come up into the pharynx will be aspirated down into the lungs. And that's very bad too, but not quite as bad as aspirating vomitus. It's not quite as bad, but it's pretty bad. But that's not prandial aspiration. That's aspiration of reflux. So we're as SLPs, we're concerned with prandial aspiration. Let me see, have I done everything? I think I've covered everything here. And you know, penetration is down just to the vocal folds, but not beyond. Okay, now, how do we describe penetration? The way of describing the penetration and quantifying it or measuring it, as I said here, is how far down into the larynx it can go. We can see it go into the top third, the top 2/3, or all the way down to the vocal folds. And that comes from a study done by Rosenbeck in 1996. And so generally when we see it occur, that's how we label it. We say patient penetrated into the top third of the larynx with thin liquids, but not with honey thick liquids, for example. I might say something like that. So it's how far down it goes, measured it in those thirds. We always want to identify the patient's response to the penetration. The normal response is to cough. We all penetrate sometimes, you know, you kind of swallow wrong. Maybe you're talking and eating or whatever, and you swallow wrong and you cough it out. You feel it, you cough it out. So that would be the normal response, but many patients with dysphagia don't. They don't sense it and they don't cough it out. Okay, then we do have two types of penetration. One is referred to as transient penetration, and the other is referred to as cumulative. Initially, they look the same. You see a little line when the larynx is supposed to be closed. You see a little line going down maybe into the top third, but not beyond. And then as soon as they open up their airway and take a breath, you don't see anything. You don't see anything in the airway. And so generally what you would do is you give them another swallow like that. You keep going and see, does anything ever get down to the vocal folds? And if it never does, every time they swallow, we see the top third being filled a little bit, but after they open up, they don't see anything and it never gets down to the folds. That's transient. We'll talk later about exactly what that means and what the interpretation of it is, but suffice it to say, you'll see that a lot, that patients do show what appears to be penetration, but it never accumulates or does anything. It never gets down to the lungs. It's non-handicapping. Cumulative penetration, on the other hand, it's potentially handicapping because if you keep swallowing the same thing, and let us say on the first swallow, it goes top third, second swallow, top 2/3, third swallow down to the vocal folds, fourth swallow, it's going to go below the vocal folds, and there you have the aspiration. So it's potentially handicapping because it will inevitably result in aspiration. Okay.
Dr. Kisselman?
Yes,
Regarding the difference between penetration and aspiration, how can we know for sure, unless we're looking at an MBS, whether someone is whether just penetrating or whether they're actually aspirating as well? Would we just know that? Would we suspect that if they started to get sick, maybe like show like signs of pneumonia, like something made it into their lungs?
That'd be a clue. That would be a clue. But the way we determine it is through a modified barium swallow or a fees. You can see it most clearly with a modified barium swallow, but you can also see it with a fees. But bedside, just getting the history and doing a bedside evaluation, you would never be able to, for sure, determine that they have penetration or aspiration.
Yeah, right. So like even when someone who's completely healthy, like you or I, swallows something the wrong way and we think it's penetrating because we get most of it up, we wouldn't really have any way of knowing whether we actually aspirated some of it as well and some of it made it into our lungs.
Well, if you're now normal people like you or I, well, I say more you than me, but you know, normal people will cough it up, and when it gets to your trachea, you'll cough even harder.
But if it's like liquid, I don't know, like if it's like water and you swallow it the wrong way, is there a chance that if I have that reflex to to cough it up, is there a chance that some of it would be aspirated, or is that reflex letting me know that it was truly only penetrated and not aspirated?
Well, okay, so you can penetrate or aspirate either one as a normal person, and you're going to cough it up. And generally speaking, you would cough it up well. Now, if you get into if you get and effectively enough, doesn't mean you might have 2 drops of the liquid down there, but that's the amount you can tolerate. See, a normal person can tolerate a small amount of aspiration. So if you're talking about the situation where a normal person aspirates, as we all do sometimes, and then you have the normal cough response and you cough it up, and is there a microscopic amount left down there? Yeah, probably, because you can't cough it up 100%. But you cough it up enough where it's not clinically significant.
Yeah, I think that kind of answers my question, because I was wondering when on a regular basis, because that happens sometimes where we swallow things the wrong way, whether that was a penetration response or an aspiration response. So even if it is aspiration, even if it does make it all the way below your trachea, you can still respond in a coughing manner and get most of it out, even if it's okay.
Definitely. Yeah, that would be the
normal.
I
guess that makes sense. That's why we have the Heimlich and everything, but like.
Yeah.
Yep. Okay.
That's how it would work for the normal person.
Thank you.
Okay, thank you for asking. Okay, now how do we describe and measure aspiration? With aspiration, we express it, the amount, in terms of a percentage. And the way we do the percentage is kind of rough, but it's good enough. And you can only do it with a modified Barrett swallow, by the way. You cannot do it with a clinical bedside evaluation at all, because first of all, you can't even determine with a bedside evaluation if they are aspirating or not. You can have clues, but not an objective, definitive determination. With an MBS, you can. And so the way you're going to do it with an MBS is, first of all, you'll see it happens. You'll see what impairments causes it, and you can then quantify it. And the way we quantify it is we look at the material as they hold it in their mouths. And we quantify that typically just subjectively. You can actually, there's a program that allows you to count the pixels. So you can draw a little line around the material as it's held in the mouth, and the program will count how many pixels on your video screen are held within the line. And then you have them swallow, and let's say they're aspirated down into the trachea. Then you draw a little line around it, and the program will compute the number of pixels and the percentage that got aspirated. Does that make sense? Most SLPs don't actually do that objective computerized process. They do it subjectively. They do it impressionistically. And so that's how we do it, because it takes quite a bit of time, probably for not too much clinical payoff, to spend the extra amount of time to quantify all that to that degree. And the other thing to keep in mind is, even if you spend all that time quantifying aspiration to that degree, it's not really accurate, because you're quantifying 2-dimensionally on a video screen, but the structure is 3-dimensional. So you're missing quite a bit of information. So impressionistic estimation of how much was aspirated is generally, I would say, good enough. When you see it occur, you always figure out what impairment caused it, because that's going to set up your treatment plan. You link the impairment with the treatment plan, whether it's a compensatory treatment plan or a rehabilitative treatment plan. And the other thing we always do, other than quantify it and identify the reason, is we identify the patient's response to it. And a functional response would be coughing it out, but many neurologic patients don't have that. So the goal of the instrumental assessment is to quantify it, determine the impairment that caused it, and to describe the patient's response. All right, here is a, now we've talked about penetration, we've talked about aspiration, and here is something called the aspiration penetration scale, which goes from 1 to 8. And you can see that it incorporates everything we've talked about. Like a number 1 is material does not enter the airway, meaning it doesn't penetrate or aspirate. Apparently, it might go the right, it may or may not go efficiently through the pharynx, but it doesn't enter the airway. So that's a number 1, the best score. And a number 8 is the material enters the airway, passes below the vocal folds, so that's aspirated, and the patient makes no effort to eject it. They don't, in other words, they don't cough. A little bit better than that, a number 7 is material enters the airway, passes below the vocal folds, and is not ejected, but the patient has tried. You can see that's a little better. It still doesn't work, but at least it's a step in the right direction. Number 6, the material enters the airway, passes below the vocal folds, it's aspirated, and it's ejected out of the larynx and the airway. That's what we all do. Occasionally we do a number 6, each of us. So I won't go through the whole thing, but you can see how it works. I missed my screen up here. Okay, sorry. No, okay, here. Okay, so you can see how it works, and spend some time with that. I might have a question on the quiz about it, I'm not sure, but of course you can look it up. So I want you to know how to use the scale. You do not need to memorize the scale. If I were to use the scale, you know, I would carry a little sheet of paper and look it up for the first few times. And if you use the scale all the time, you'll learn it well enough. Okay. Okay, now I just want to say a word about the categorization of impairments that cause aspiration or penetration. Basically, you can see these 3 bullet points divide aspiration according to when it occurs. Either before the pharyngeal swallow response has occurred, second bullet point, during the pharyngeal swallow response, or third, after. And I'm going to take the second bullet point to discuss it first because I kind of think it's an easy reference point. This is a situation where you see the patient swallow and the material is in the pharynx and they're pushing it down. And they could even be doing the whole thing completely normally, except one little thing happens. As it's being pushed through the pharynx, some of it enters the larynx. And the reason it enters the larynx is because they didn't close it tightly enough. So remember that the bolus is being pushed under pressure through the pharynx as it passes through the pharynx, not gravity, pressure. And so if that larynx is not closed tightly enough, it will squeeze in. Depending how weak the laryngeal closure is, it will squeeze some of it in. Could be transient penetration, could be cumulative, could be aspiration of 20% the very first time. So it could be any of those, depending how weak the closure is. So I kind of feel like that's an easy starting point, even though it's not in the sequence here. Are you all comfortable with that particular impairment and how observing the timing of the penetration or aspiration tells you what the impairment is? It's during the pharyngeal phase when you see it passing under pressure past that point of the laryngeal additus, the opening into the larynx. Okay, now let's take this third bullet points. And this is aspiration or penetration that occurs after the pharyngeal swallow response. Okay, now how does that work? In this situation, the patient has completed the swallow, it's done, and they're starting to breathe again. It's as over as it's going to be. And you see something at that point enter. What has happened is they haven't cleared the pharynx. And they have so much material in the pharynx that some of it has to go someplace. Where does it go? Into the airway as soon as it opens and they take their first breath. So that's aspiration or penetration after the pharyngeal swallow response. And it comes in two forms. One is due to impaired pharyngeal motility, and the other is due to cricopharyngeal dysfunction. And that making that differentiation depends upon where the residue or stasis is located that then gets aspirated. If it's way up in the valleculae, which is that little recess just between the tongue and the epiglottis, or if it's down in the piriform sinuses as well, or if it's basically the whole pharynx, they've got so much residue and they open up their airway, take a breath, and it goes in. That's referred to as impaired pharyngeal motility. So it can be just in the upper part, or it can be in the whole pharynx. But if it's only in the lower part, that is due to cricopharyngeal dysfunction. And what has occurred in that situation is that the pharynx has done its job of pushing material down, and that's why you don't see any residue up in the top part of the pharynx in the epiglottic valleculae. But the UES, upper esophageal sphincter, has not opened up enough, or it's not opened up long enough to let the whole thing get through, and the patient aspirates the residue. So they will be aspirating material at the base of the pharynx. So either way, the aspiration is after the pharyngeal swallow response, but it depends where the stasis has been located that was resulted in aspiration. Upper part or whole thing versus lower part only. You good? Okay.
Professor, can you clarify one more time?
Huh?
The upper part is pharyngeal motility? There's an issue with pharyngeal motility.
Yes, Marlene, if it's in the upper part alone, or if it's in the whole pharynx, including the upper part. In other words, you've got to have the upper part involved in this to label it a pharyngeal motility deficit. If it's only in the lower part, that will be a cricopharyngeal dysfunction.
Mm-hmm.
Okay?
Okay.
Okay.
Wait, I'm sorry, before you move on. So the lower part is the cricopharyngeal dysfunction, but you said that starts at the base of the pharynx?
Well, what happens is you see the stasis at the base of the pharynx.
Okay. Thank you.
You're welcome. Okay, now let me pause my recording for just a moment and ask you a question. We're going to pause. All right, I'm resuming the recording, and I'm going to stop sharing for just a moment just to make sure it is recording, and yes, it is. Okay, so good. I'm resuming the recording, and we are on slide number, what is that? My computer is catching up. Sorry about that. Okay, we're on slide number. Okay, we're on slide number 13. And it turns out we have more like 7 slides to go, but I'll go fairly quickly, so hopefully it's okay. We finished the second bullet point and the third, and then the first bullet point has to do with those 2 situations where aspiration occurs before the pharyngeal swallow response. And in one, I think this is kind of easy to understand. The patient is processing the material in their mouth. And basically at some point in the process, they lose some of the material down into the pharynx. And that can be aspirated at that point. Because it turns out that in order to generate a pharyngeal swallow response, you have to first transfer it. It's got to be a deliberate oral transfer movement. If you just plain lose it, you won't have a pharyngeal swallow response. In other words, the throat doesn't just kick in because something arrives there. What happens instead is you aspirate it. Unless they're like the epiglottic moleculae, you can accommodate about a teaspoon there. But if it's more than that, it's going to be aspirated. And then the second situation is a situation where there's a delayed or even an absent pharyngeal swallow response. So the transfer has occurred, and it can be a deliberate oral transfer, and you should have a pharyngeal swallow response, but it could be a couple seconds delayed or 3 seconds delayed, or maybe it doesn't happen at all. And that in that case, you'd have aspiration before the pharyngeal swallow response. Differentiating those two is kind of tricky, but we will practice it. You'll get quite good at it. But in either case, it looks almost the same if you're looking at a modified barium swallow. The aspiration is before the pharyngeal swallow response. And it turns out actually that some of the, especially the compensatory treatments for these two situations would be the same. I didn't mean to do that. Yeah, would be the same. So in part differentiating between premature loss and delayed pharyngeal swallow response doesn't matter. Now, if you're going to do rehabilitative treatments where you're trying to get at the underlying problem, it does matter then. We'll of course, we'll spend a course on that. Okay. I think you kind of are familiar with this, but I just wanted to review the difference between impairment, disability, and handicapping or handicap. Is we said I'll treat the fourth bullet point first. We're only going to treat handicapping impairments, generally speaking. There might be some exceptions to that, but not many. So what's an impairment? It's any loss or ability, abnormality of a psychological, physiological, or anatomical structure or function. So for example, you know the 9 impairments now. Let's say when they swallow, you see 20% residue in the pharynx. Every bolus leaves behind 20%, but they never aspirate it. They never choke on it. They don't have to change their lifestyle. They don't seem to be annoyed by it. That's an impairment, but it's not a disability or a handicap. Okay, so now what's a disability and what's a handicap? A disability is any adverse change in ability to perform an activity that is considered normal for people in general that is caused by an impairment. So you're looking at the impairment and then you're saying, well, does this change them compared to other people? Compared to other people. And then the handicap is in reference to that person. Let us say that they've had a stroke, they've got an impairment, you can see it on the MBS, and you know from their history that they didn't have the impairment before. And so you're asking, is it handicapping? You're referencing it to that person. Did they have to change their lifestyle? Did they develop a situation such as choking or such as aspiration with a potential for aspiration pneumonia? Since they had that stroke, that would be handicapping for that individual. So generally we think about it like that we're thinking about the person in front of us. They have an impairment. Have they had to change anything, or have they had a complication compared to where they were before? And the reason we do it with reference to that person and not the population is because some people, due to other problems that they have associated oftentimes with advanced age, have already changed their lifestyle, have already adjusted their diet, have already, they don't do certain things, they don't engage in certain activities, and now they had a stroke and they have an impairment, but nothing changes so, as far as their activities or their complications. So for that individual, it wouldn't be handicapping. It might be disabling compared to the population, but we're referencing the individual. Have they had a change that is functionally meaningful as a result of their impairment? Then that's a handicapping impairment. And how do you find that stuff out? Through history taking. You sometimes can get it from the patient themselves, from a loved one, from a history that's written and provided. So that's the way we do it. Okay. Let's see, I keep going backwards here. So In dysphagia, we treat impairments only if they are handicapping. And here's an example of a handicapping impairment. It's a delayed pharyngeal swallow response that results in aspiration when an individual aspirates thin liquid while taking self-regulated doses from the edge of a cup, but not when taking a half teaspoon doses from a spoon. Okay, so it's not that they aspirate all the time, but they do when self-regulated doses are taken. In other words, they're just drinking from a cup as they normally would, as that individual normally would, but now they aspirate yeah. So an example of a non-handicapping, actually I've given this example I think 2 times in the same lecture, that somebody has pharyngeal dysmotility and they have 30% residue left behind, but they never aspirated, they never coughed, they never choke, they didn't have to do anything different. So they don't have a handicapping situation. Okay, treatments. They divide into compensatory and rehabilitative. I'm just going to give some examples, but I'm going to refer you to a document that I posted for you from University of Texas. Just maybe print it out. It's only, I think, 4 pages. It's not very long, but print it out and kind of keep it with you the whole course, because as we go through things and we identify impairments and you're going to think, well, what could we do about it? You're going to have these choices and other ones too, but I think it's a nice little summary. Definitions. Compensatory treatments involve changes in the diet, the posture, the dose size, the method of ingestion, or the swallowing pattern. For example, if you ask them to swallow 2 times every dose, that would be a change in the swallow pattern. Rehabilitative treatments involve procedures intended to improve the underlying physiology of the swallow. Exercises, strengthening exercises, stimulations of various kinds. You've heard of E-stim, probably heard of E-stim, or sometimes called vital stim. That's a treatment intended not to compensate, but to change and improve the underlying swallowing function. Here are examples of compensatory treatments. They would be dietary adjustments, and we'll go into all the details of that later. Position adjustments, such as being upright more. You can adjust position and posture for premature oral loss, delayed pharyngeal swallow response, reduced pharyngeal motility, and cricopharyngeal dysfunction. In other words, 4 out of the 5, 4 is, how many is that? 1, 2, 3, 4. 4 out of the 9 impairments can be taken care of that way. And maybe others too, but at least that. Changes of dose size or method of ingestion. Generally speaking, when people have dysphagia that is handicapping, they have an impairment that's handicapping, we reduce dose size, almost always. Smaller sips, smaller bites, not bigger. And I'll give you an exception or 2 as we go through the course. We also teach independent or dependent use of compensatory swallowing strategies. The Mendelssohn swallow is where you swallow hard and hold it. Just swallow and hold. And if you're holding properly, you cannot breathe until finally you release it. And now you can take your breath. And you'll see the Adam's apple goes up and stays up as long as you're holding it. That's a Mendelssohn swallow. But you can't breathe. Relax, Adam's apple goes down, take your breath. Now your Mendelssohn swallow is over. And what's that for? Reduced pharyngeal motility and impaired cricopharyngeal dysfunction. The idea is to try to intensify that phase of the swallow to get material through the UES. The supraglottic swallow is for poor laryngeal closure. I'll give you a quick description of it now. I don't use it much because you'll see it's really hard to learn. And you can't have a cognitive dysfunction and learn the supraglottic swallow. The supraglottic swallow involves taking a breath, holding the breath, swallowing, coughing, and swallowing again. What is that? Is that 4 or 5 steps? You got to be pretty good. And there's no way to kind of coach somebody through it for every swallow. If they have a cognitive dysfunction, it's just not going to work. So they've got to learn it. I had one patient who aspirated and had pneumonia multiple times, and he had a hemilaryngectomy that was the impairment. And it was for poor laryngeal closure, hard to close your larynx when you have half of it gone. And he successfully learned the supraglottic swallow, and we could see on the modified Barron swallow that it prevented aspiration, or at least he coughed the aspiration out. And he finally said, you know, I can do it, but I'm not going to. And he accepted to get aspiration pneumonia occasionally because that was so hard for him. Okay, then the double swallow for reduced pharyngeal motility, it's kind of easier, and you can coach somebody through, even if they have a cognitive deficit. For every dose, they swallow twice. What's that for? Reduced pharyngeal motility. And then dose regulation for premature oral loss, delayed pharyngeal swallow response, reduced laryngeal closure, reduced pharyngeal motility, and impaired cricopharyngeal function. In other words, we do that for almost everything. And I see that I have dose regulation up here, but that I've been redundant and listed it twice. Then rehabilitative treatments. These are just examples. Oral motor exercises, thermal and gustatory stimulation, laryngeal closure exercises, the same one that you learned in your voice class. The shaker exercise, which is kind of like a sit up with your neck. In other words, you lie straight and you lift your neck up and you do, or head up, and you do it 10 times, and that's to improve pharyngeal motility. And then E-stim, which is an electrical stimulation. So I believe that is it, except to remind you to print out swallowing strategies from the University of Texas in the information or management and treatment section of the course website, and you will refer to it often. I actually put it in the module 1, so I think it's right there. And I believe that's the end. That is the end. Now, if you have questions, email me and take your quiz anytime, repeat it, etc. And let me know any questions you have, and I'll be happy to help. And other than that, I will see you next week. I'm going to stop sharing and stop my recording.